see here, what I'm doing is I keep the small wheel in the center and I'm locking the small wheel so that when I move the big wheel up and down, it's moving only in one plane, as you can see here. It's moving in one plane. I'm going to keep it in front of the camera. So when I'm going across the cricopharynx, I'm going to move the big wheel of the scope a little bit away with my thumb. And then you should also get the endo picture now. So if you get the endo picture, are you getting the endoscopy picture?
No, Amit, no,
Okay.
we have it.
Now you see here, when I pass the scope behind the tongue, you see the tongue above, it's the inverted picture. Now I make the big wheel little up so that my scope goes behind the tongue. There you start seeing the epiglottis. Now over here, I'm going to push the scope little bit up and then little bit away again, the big wheel, so that I go on the posterior pharyngeal wall. Now once I'm here, I'm going to rotate the scope slightly and give a gentle push, which enters inside the esophagus.
There should be no resistance on this process.
No resistance. And if you find the resistance, you have to again pull back and go in a proper way. Now, after I entered the esophagus, I'm releasing the small wheel. I keep the big wheel pressed little away, give a little air. You see what I've done? I've converted the side viewing scope to a partial end viewing scope. I can actually see the lumen of the esophagus so that even by mistake, we don't create an inadvertent trauma if there is any narrowing or a stricture. So we are going slowly by slight rotation of the shaft, left and right, intermittently make the big wheel up. Now as I go to the OG junction, you see here, I make the big wheel little up and turn the shaft of the scope to the left. You can see the fluid in the stomach fundus. So now I'm going to suck that fluid in the stomach fundus, suck it until the stomach is completely dry.
It's necessary to us to push how much air in the stomach if you're getting to
very little bit of air, because the more air you push, you may loop your scope inside the stomach. Now here you can see that I've just entered the stomach. On the left side is the fundus with the fluid. On the right side is probably the antrum and the place where we want to go. So I'm going to now turn the shaft of the scope a little bit left here, make the big wheel up and suck this fluid even more. And especially because I'm doing the procedure in supine position, I don't want any fluid in the stomach which can come up and cause the patient to aspirate. So now I'm going to give a little bit of air. I just push the shaft of the scope inside a little bit. And now I want you to see what I'm doing. I'm gently turning my whole body to the right. Now, as I turn my body to the right, automatically I start seeing the antrum of the stomach and the incisor angulans. Not too much of wheel turn. In fact, I have not turned the wheel at all. Now, once I come into this position, now I just keep on pushing the scope along the greater curvature of the stomach, and in between by turning the shaft this way and this way, try to keep the pylorus in the center. So keep on pushing, keep on pushing, keep on pushing, keep the pylorus in the center until we get what is called as the sun setting sign. So you go there, and when this lip of the pylorus disappears, my scope enters the duodenal bulb. Now at this stage, one should not be in a hurry to immediately turn to the right. At this stage, you should push the scope a little bit more and now turn the body to the right, and then you see what you are going to find. You will start finding the junction of the first and second part. So at this level now I am going to turn the small wheel to the right and I fix the small wheel. So now the scope is hooked at the first and second part. And now as I am turning the big wheel with my left thumb up, I am gently pulling the scope backwards. Not necessary to twist the scope too much on the right side. Now as I am pulling the scope backward, you see the major papilla I have already passed and the scope has gone beyond the ampulla of Vater. So now I'm going to keep the shaft of the scope here, derotate the small wheel to the left, keep the big wheel pressed away, gently keep on pulling the scope behind until I bring the ampulla of Vater somewhere at 11 o'clock in direction. Now I've kept the ampulla of Vater at 11 o'clock in the field. Now you see, if you see the bulge of the ampulla of Vater, you have to orient the small wheel in such a way that the bulge is going from right to the left, from below upwards. So now this is how you can find this is the ampulla of Vater. Because this is the patient of stone disease, many times you get such a good ampulla where the ampullary orifice is not very tightly closed. This is a hallmark of stone disease. If you have the same patient of CA head pancreas or a malignant obstruction, you are not going to have such a cakewalk ampulla. So now what we do, already we have seen that we have in the initial lecture series that spoke about sphincterotomes, guide wires, etc. Normally what I do is to use always a sphincterotome when the indication is for therapy. You can see this is the sphincterotome. Now you bend the sphincterotome. You can see that the sphincterotome is bent. And now what you do is in your mind, you should know in which direction to go. So I want to go now, starting from here, in this axis, somewhere over here. And the guide wire I usually use for access is this 0.032 stereomo glide wire, which can be rotated. You can see how the wire can be rotated. So now, if you want to do the cannulation without a guide wire, what is the technique? So take the guide wire back. I just first go in the orifice like this, and now bring the big wheel little near so that the sphincterotomy is towards the axis. Now I'm turning the small wheel little right, and then my assistant rotates the guide wire. You see what has happened there on the fluoroscopy?
All the way to the liver.
The guide wire is automatically entered only because we have given him a good axis. So what is necessary in selective cannulation is going inside, lifting the roof, rectifying the axis of the sphincterotome towards the axis of the bile duct, and then the guide wire has to be pushed and rotated. So now you see what has happened. The guide wire has entered inside. So without putting any contrast over the guide wire, I'm going to go up right till the hilum, because this patient is likely to have multiple stones. I'm not going to inject contrast from below upwards, otherwise the stones will be pushed up. So my sphincterotome is now gone up, and now I'm pushing contrast from above downwards. And gently I pull the sphincterotome down. You can see that this patient has got some small stones in the bile duct. You can see that. So now I will replace the guide wire, and then I will proceed with the sphincterotomy. Rangsen, any suggestions here?
No. This is perfect. I mean, this is a very excellent demonstration. Just a question for, I think, as a beginner, apart from using sphincterotome, any specific guide wire you recommend? I mean, in terms of straight tip or J tip, or what? The special design in your experience?
I prefer usually the angle tip wire, Rangsen, because the lower end of the bile duct, especially at the ampulla, is a S-shaped portion. So if
Right.
you use a straight wire and try to cannulate, sometimes you can create damage to the epithelium. If it enters the pancreas, also you can create damage. So that's what I do. So actually, Rangsen, to tell you the truth, the simplest case of this I've kept myself. All the difficult ones I've kept for you.
Okay, I will see. Thank you for that. The other thing that since you got in quite nicely, but I mean, for those who didn't get in, any trick to move your catheter, if you already done in terms of very good, position or direction, any change or adjustment that you would suggest?
Yes.
When they try or to do
That's
at
very
that
important question, Rangsen. What is important is after you have brought your sphincterotome in the right axis, very micro movements should be done of the wheels, of your body, of the shaft of the scope. Don't do any coarse movements. You have to understand that the ampulla of Vater is a very delicate, tiny organ surrounded by vital structures.
Right.
So if we damage it because of repeated, deep, and harshful cannulations, we are likely to create complications. So now what I'm doing now is doing a sphincterotomy. So I've kept 1/3 of the sphincterotomy wire inside. Now I want you all to concentrate on my hand. I'm going to hold the shaft of the scope here. See that? So bring the camera down and concentrate. See. So the movement of the wire, I'm going to control by this movement. See, look at the shaft.
So you're cutting with your right hand instead of left hand.
And with my left finger, I'm moving the big wheel in and out to bring it near and away from the papilla. So now you bend the wire, please. So now the wire is bent, and now with my right hand, I'm controlling the direction of the cut.
How much can you cut for the beginner? If you look at this one.
See, ideally, you should cut depending upon the size of the stones, the dimension of the bile duct, and the size of the ampulla of Vater. Right. So now here the stones are not very big, so this much amount of cut should be sufficient. So I'm taking out the wire, and I'm just going to pass inside a stone extraction balloon.
So in India, is it more common to use balloon or basket?
Yes, I think initially I used to use basket because I was trained by Nip Sohendra, but on a few occasions, of course that time I was young, I was a little aggressive, and some stones I tried to remove, my basket got stuck, and then my basket had to be sacrificed for a mechanical lithotripsy. So if you want to be very safe, balloon is always the safest technique to do, because balloon will never get impacted. At the most, what will happen is the balloon will get burst. So here I am using the Boston Scientific stone extraction balloon. Now I want you to concentrate on the X-ray picture. I'm not going to go up and pull the stones down. So you have to take out balloon, the stone by stone, starting from the lowermost stone first. You see here now, I'm going to gently pull the
So
balloon.
watch his hand in terms of pulling.
See what I'm doing? And now I've got a very, very trained and a smart nurse assistant over here. So what I'm doing is, as I'm pulling the balloon, she's automatically pushing the scope and rotating it. If you have some such type of an assistant, your procedure becomes extremely easy.
I just realized you got the third hand.
Yeah. So now see what I'm doing? Don't push now. Wait. Second stone. The first group of stones came, then the next group of stones came.
I mean, if it's very small stone, I'm just lazy and just do it from the top. Is that okay?
Yeah,
or?
it can. I mean, if you are very experienced, all will come like a train. So gently pulling, gently pulling, gently pulling. Looks like we are almost getting it over. But one stone is there above. So now I'm going to push the balloon, pull the wire, please. Yeah, okay. But yeah, very good. And now I'm going to pull. Gently pull, gently pull, gently pull. And then the last stone is also come out. So it looks like it is over. So what I do is, if there's some little bit of oozing here, there are two small tricks I want to tell you. Number one, we have always kept a bottle of saline in the deep freezer. So it's an extremely cold saline. So what we do is, we flush the bile duct with extremely cold saline, and then we inflate the balloon also with cold saline and keep the balloon inflated at the ampulla obiter with very cold saline. And we have found this to be very, very useful technique. Okay, so now we inflate the balloon a bit. I just want to show you how we inflate it. Yes. Keep it pressed here and just wait there for 5 minutes. Here, of course, it's not required because the bleeding has already stopped. This bleeding occurred because the stone rubbed against the sphincterotomy. Now, because this patient has also gallbladder stones, it is our usual. We place a temporary 7 French pancreatic stent. Patient.
I see. This is a reason to prevent stone migration? I see. All right.
Stop the procedure here.
Excellent demonstration, Amit. This is a great start.